But if you really want to do two things well, what are the two things wrong? Let's have some success. I wanted to say, everybody wants to see it well.
It was
Okay. Where? No, I don't have it. What? So then I go to EHR. I go to the EHR. Yeah, no, I'm not taking any notes. I have some new meds from Honduras and from California, and this is all in Spanish.
Our first talk is on the new landscape of tobacco products, evolving clinical response. Jim Martin is the first speaker. He's Director of Policy and Programs for the North Carolina Tobacco Prevention and Control Branch at the North Carolina Division of Public Health. His major responsibilities include expertise on tobacco use prevention and control policy and programmatic solutions. Prior to his current position, he served as Field Director for Policy and Programs with Project Assist, now known as the Tobacco Prevention and Control Branch. He also served as Governor James Hunt's advisor on teen tobacco use prevention. Prior to Project Assist, Jim served as a staff member with the National Cancer Institute's Commit Project in Raleigh, North Carolina. He's published several articles on tobacco use prevention and control, and he's conducted numerous local, state, and national level presentations on policies and programs to prevent and reduce tobacco use. Introduce Stephanie so we won't have to break up before the second half. So the second speaker is Stephanie Gans. She's a licensed clinical addiction specialist, licensed clinical social worker associate, as well as a certified tobacco treatment specialist. She has experience working in community mental health, FQHC, and FQHCs. She has experience working in medication-assisted treatment, as well as with a number of marginalized populations, such as those living with severe and persistent mental illness and substance use disorders. Presently, she's a tobacco treatment specialist for DPH Tobacco Prevention and Control Branch. She provides expert statewide training and technical assistance to promote evidence-based tobacco use treatment interventions in medical and behavioral health settings. They will do the first talk on the new landscape of tobacco products, and then that will be followed by Dr. James Finch, who's already been introduced enough here, who will talk about behavioral addictions. So please welcome Jim Martin.
Good afternoon, everyone. So I hope everyone's doing well. It's a great conference treating nicotine addiction. So let's get started and give you a kind of a context. And let me just say that I've got a lot of slides. And I'm going to try to keep it somewhat at a high level on several of them, and then some of the slides I'll drill down a little deeper into give you a little bit more information. But let's just talk from big picture to begin with, and look at tobacco use as a whole. It's responsible for 1 out of every 5 deaths in North Carolina. And in the Surgeon General report in 2014, it was reported that for every death, we have 30 more people who are living with a tobacco-related disease. Obviously, that reduces their quality of life quite considerably. So that adds up to a huge amount of healthcare cost, as you all know. I mean, the latest estimates, and this is 2009 dollars, and so we are way behind in calculating the actual cost, but over $3.8 billion at that point in time in excess healthcare costs. You can see Medicaid cost at 931, and then also cost as it relates to non-users who have been exposed to secondhand smoke and also breathing toxic soup of secondhand smoke and have chronic conditions as a result of that exposure. As far as looking at adult, specifically if we look at smoking rates in North Carolina, we have the trend line is going in the right direction, but not accelerating to the level, especially in North Carolina, that we'd like to see. As a nation, we're at 14%, both historically the lowest levels that we've seen over the last century. And then we have optimism at the national level as we can continue that curve. We'll get down to the 12%, which was our 2020 objective as Help for Healthy People. So we need to accelerate that curve in North Carolina especially. If we want to talk about prevention and what leads to adult smoking, we have to talk about our kids. Because 90% of the people who start using tobacco products start before the age of 18. That's an early age to make a decision that can lead to a lifelong addiction to a product. And so this is the best slide. I wish I could just stop here and just conclude with this slide. Because this is the best slide I'm going to show you. This is the trend line of looking at reducing cigarette smoking for our middle school and high school kids. If you look at 1999 and before that time, I termed that as a Joe Camel generation. We have kids that were taking up tobacco use, especially cigarette smoking, Marlboro, Camel, to levels that we saw historic highs. We were over 31% of high school students in 1999. 15% of middle school students were smoking. Through policies, media, funding, national, state, and local efforts, we've driven those numbers down through prevention work to the lowest we've seen. Now we're at 8.9 for high school and 2.5 for middle school. But turning the page, turning to a new chapter, we have a whole new landscape that we're trying to deal with. And that comes out of these types of products, e-cigarettes. So what we've seen is an opposite trend line that we've seen with smoking for the last couple of decades, but just in the last few years, we've seen this type of trend line with e-cigarettes going from 1.7% in 2011 to almost 17% in 2017. Almost a 900% increase in use among high school students, almost 500% you've seen among middle school. And when asked the question in 2017, would you anticipate experimenting with one of these products in the next year, we had over 23%. We're in the field right now with our 2019 Youth Tobacco Survey with middle school and high school students, and we should have data in early 2020. But we are far underestimating the problem at this point in time, would be my best guesstimate. If you look at all tobacco product use, you can see that now the most used product is e-cigarettes among our high school and middle school students. And you can see the other types of products that our youth are beginning to get nicotine. And some are dual users and poly users as well. But a great number of e-cigarette users. So that's driving up our overall tobacco use rates with a trend line that was going down since 1999 with overall tobacco use. Now it's beginning to go back up. We're going in the wrong direction. In fact, that 30%, you want to look at that from a kind of put a perspective on it, is that if we started lining up school buses and loading them up with high school kids right outside the front door, by the time we got to 38.8% of our high school students who are using some form of tobacco, we'd have up to almost 50 miles of back-to-back buses lined up. So it gives you some concept of how many youth we're talking about here. So here's national data from the National Youth Tobacco Survey, and we saw a huge increase in e-cigarette use between 2017 and 2018, going from 11% up to almost 21%. The greatest increase we've seen of any time, especially since this data has been collected. And if you want to look at monitoring the future data, it's the first time in 45 years that they've seen this type of increase in just a 1 year period, which was very reflective of their survey as well. And then if you look at this data, this is the newest data that we've got from the National Youth Tobacco Survey. And in fact, the green bar is the 2019 data, and that's preliminary data right now. But you can see that the level has gone up nationally to 27.5% at this point in time. So this is increasing quite dramatically over time. The increase that we saw in 2017, between 2017 and 2018, gave enough data to CDC and the Surgeon General and the FDA to term this as an epidemic. So we're dealing with an epidemic here with youth use of this product. This also has a couple of other data points showing the trend lines for all tobacco products, but you can see this big jump with e-cigarettes, same thing with middle school students. So how do we get here with these products?
Can we ask what youth, what ages is that?
Middle school and high school.
So what's the youngest age? Is 12 or?
Yeah, 12.
Okay.
12
Yeah,
to
like
like
6,
16?
through 8, and then 9 through 12. So 12, basically 12 to 18. Yeah.
How did this get on the market so fast?
Well, let's explain that. So let's talk about these products. They first came to the market in about 2007. We've had several generations of the product. The first generation were these Cigalites that you see. Some of you may have seen these being promoted through companies at a mall and to actually being promoted to help people quit smoking in terms. So they look very much like a cigarette, containing cartridge of nicotine. And then once the product is being used, the battery or the cartridge, the liquid nicotine is used up, you dispose of the product. Then the next generation came along with a rechargeable brand where you actually buy separate cartridges. You can actually plug the overall cartridge in and get the battery life extended. And then the third generation were these tank systems, pen systems, pen vaporizers, they're called, where you can basically add nicotine to the products. And you see the big ones down below, the mods, they were called. And then Juul came along, is basically the fourth generation, or a pod generation. And I'm going to dig down a little bit deeper on Juul in a few minutes. But these products began to proliferate on the market to be advertised, and you can see some of the old ads bringing back that we fast forward to the new ads, very similar types of getting stars and other celebrities to start promoting these products. And here's an example of a Juul ad using young models that can, again, sell these to youth and young adults. And so these products basically multiplied onto the landscape, and in 2014 published research showed that there were over 460 brands and over 7,000 flavors that were introduced to the market. That's 2014 published data. The California Department of Health has estimated now that there's over 15,000 flavors actually on the market at this point in time. So kids are really interested in flavors. 81% of the kids are using a flavored product. These come in multiple candy flavors, gummy bear flavors, Captain Crunch flavors, you name it, those flavors are on the market. And in fact, the fruit flavors and also mint and menthol were the two highest in the 2019 data that we're seeing, preliminary data of kids that are using on the market. So the combination of advertising, which is being totally unregulated, as well as flavors, have really attracted kids to this. And the analogy that I would like to share with you is that it's kind of like the advertising has driven basically the kids to the water, the flavors are making them drink, and then the nicotine keeps bringing them back, cycle that we're in. So what kids are breathing, they think it's water vapor. And if you ask kids, they'll think it's basically harmless water vapor. And that could be, that is really false. And we've got to correct that as much as possible. Basically what kids are breathing in is an aerosol. It contains chemicals. So what chemicals are in here? So nicotine obviously is a high level and very addictive. The flavors themselves, we've never had people breathing in flavors. We can digest flavors through our foods and drinks, but the digestive system is set up much differently than the lung system is set up. And so there's cause for concern for breathing in these flavors into the lungs. There's also been found several other toxic substances that are in there. Ultrafine particles that can go deep down into the lungs. Propylene glycol is a solvent. Vegetable glycerin is also a solvent that can cause respiratory illness. And then heavy metals have also been identified in these products in the aerosol. So people often ask about secondhand aerosol as well. So if a non-user is being exposed to what the user is exhaling, that cloud of aerosol, what are they being exposed to? So these same chemicals are that a non-user would also be exposed to. So clean air is the standard, and we really need to look at that. And everywhere that we're smoke-free, that we're reducing secondhand smoke exposure, we need to also reduce secondhand aerosol exposure as well. So Juul came along in basically 2015, and by 2017, kids had gravitated to almost exclusively to this product. It's a product that's produced in the U.S. out of San Francisco, Juul Labs, And they turned the industry in many ways on its side by designing a product that was very techy, looks like a USB drive, and it really appealed to kids. So teens have said that this is a really discreet product, that they're simple to use. Pod inserts, inhale. The user basically inhales the nicotine aerosol. Comes in multiple flavors, and a new term was developed called Juuling. No longer thought of as vaping, which was set aside for another group of kids that were using these types of products, but Juuling, those are using the Juul product. It was introduced as kind of the new iPhone for youth in many ways. And so if I was in a group of youth at this level and I asked in 2016 or 2017 how many people have heard of a Juul, every hand would have gone up. If I had been with adults in the same group as you are and asked that same question, probably maybe 2 hands would have gone up. And that's what was happening because youth were finding out about this product, being pulled into the market to use the product. Adults were kind of on the side, not understanding what this product is all about, not even understanding that it was an e-cigarette. These things were beginning to come into schools and teachers couldn't identify them as an e-cigarette. They thought they were USB drives or some other type of flash drive.
Huh.
So they come in, as I mentioned earlier, the flavors really attract kids. The flavors that came on the market to begin with Juul was Fruit Medley. They've since changed that to Fruit. Creme Brulee was also a flavor. They've changed that now to just to Creme. Cool Cucumber was also a flavor that was which has been now recently changed since there's been so much criticism of Juul in their flavored products. So it's now just Cucumber. The thing about Juul is that they changed the design of the nicotine solution to a nicotine salt. So they went into the lab and really designed a new way of delivering nicotine. Nicotine salts changes the product by adding benzoic acid to the nicotine solution, which changes the pH down to more acidic. And so when you change it to an acidic level, it's not as harsh on the throat area. So they bumped the level of nicotine up to very, very high levels. So 59 milligrams per milliliter was almost double that of any other product that had been on the market to that time period. And so the 59 milligrams per milliliter is often disguised on the box because it says 5% by weight. And so no one would understand 5% by 5% of nicotine, but it's 5% by weight of nicotine, which is 59 milligrams per milliliter. One pod itself, which is about the size of a nickel, the pod size, contains the nicotine levels of an entire pack of cigarettes. And so there's been estimates also that it's beyond that because a cigarette often burns when the user is not using it. So it sits on the side, and so a lot of the nicotine that's in a cigarette gets burned off when someone's not inhaling on it. The only time you're using nicotine from an e-cigarette is when you're inhaling on it. So there's been estimates from Stanford Medicine saying it's more like a pack and a half, potentially 2 packs that people are inhaling from these products. And this is a spike line. They perfected a product, and Steph's going to refer to this as well, because this is a product that's highly addictive for our youth. It follows basically the same spike that you get with a cigarette, which we know has been designed to be as highly addictive as possible. And so here's another ad from Juul, again showing young models. And here's the other ad campaign that really took off in Times Square, in all the magazines that youth were reading, high youth readership. And this is the same company that said, basically, we want adult smokers to quit using cigarettes and switch to our product. If you're designing, you had some of the best media and marketing experts in the country at your disposal, and you're designing a campaign for adults who are trying to quit smoking, I'm not sure this would be the exact ad campaign that you would be running all over social media with Instagram and Twitter mainly. And Juul also paid for basically youth influencers on YouTube and basically on Twitter and Instagram to pay them to actually advertise their product. And this is what went basically viral. So in other words, you start a campaign and then you actually get youth influencers to continue that campaign. So Juul's market share is in red. Here's the trend line that they've been on since 2015, and you can see that it really took off in basically 2017. And their competitors, which are the big tobacco companies here that also began to produce their own e-cigarettes to get into this market, have been outsold by, we look at the market share of Juul in comparison to big tobacco companies. So it's 72% of the market with Juul. And so then Big Tobacco started also replicating the look and design of the e-cigarette to this more pod type of system. So Philip Morris and others designed, and RGR designed their own products to mimic the look of Juul, and there's been many other knockoffs that mimic the look of it. But one thing that we're also, and I'll get to here, one thing that we're also really conscious about is that starting with e-cigarettes can potentially lead back to using other combustible products, even in cigarettes. So the trend line that I showed you earlier has potential to get reversed by the high use of these products. So nicotine itself is really a cause for concern, especially for our youth. So if you focus on the bottom block, this nicotine is really bad for the developing brain. We know that the brain is developing up to about age 25, and it has definitely a negative effect as it relates to memory and focus and attention span. And so nicotine is really bad there. We've also seen poisoning with kids getting their hands on, especially the liquids, and either on dermal or swallowing those nicotine solutions can be very deadly. And we've seen huge numbers of calls to the Poison Control Center by kids getting their hands on these. And of course, there's interference with fetal development as well. So nicotine poses a lot of threats. There's been a lot of talk about, well, what about users who are tobacco users, who do use combustible products, who may be trying to quit using these products? Well, let me just say, first of all, very clearly that that's not evidence-based. There's no e-cigarette on the market that's been again approved by FDA as a cessation device. And we only have about 3% of adults who are self-reporting that they're using e-cigarettes. And of those, most of them end up being dual users. There's people trying to quit an e-cigarette product but end up being dual users. So they're not only having the combustible product being used, but they're also using the aerosol product as well. A lot of research has been going on, especially around the country, but I wanted to hone in on a couple researches that here in our state, at UNC School of Medicine. So Dr. Taryn and Dr. Sassano have been doing research really looking at the cell's response when it's exposed to the aerosol. And we see basically that cells die. They begin to die off in relation to exposure. Only a few puffs and cells get to be really stressed. Just a few other additional puffs and cells begin to die. There's also been, as I mentioned earlier, there's been a lot of research and research going on at UNC around the particular health risk of breathing in flavors into the respiratory area. So we already know that flavors can be deadly because we know people have heard of popcorn lung, obviously, which was developed from more of a worksite setting where people were being exposed to the buttery flavor in microwave popcorn and were exposed to the chemical diacetyl, which again caused irreversible lung damage. So diacetyl has been found a lot in the flavors that are in e-cigarettes as well. With e-cigarette users, as well as smokers and non-smokers. And this is a recently published study, and I'm not sure this is going to show up really well, but hopefully you can see this. This was a non-user over here with a bronchial area, very pink, healthy, and then the cigarette user, bronchial area looks really inflamed. There's a lot there, and you can see that there's a much reddish area. Then the e-cigarette use, this is what we saw, and they were seeing consistently across, almost look like chemical burns that are occurring in the bronchial area just because of the exposure they're getting to the toxins within the aerosol. So we don't know exactly what this is going to do long term, and everything that I've been talking about thus far, starting with a product that's probably going to lead into chronic disease. All the science is telling us that, and the nicotine itself, unfortunately, is addicting a generation that's going to potentially have this generation addicted for a long time, because the way we got out of cigarette reduction is through prevention, not as much as treatment. But now we have a new epidemic on our hands, and you all have seen a lot of press coverage about this recently. And this is the newest data that was from the CDC call at yesterday at 4 o'clock. And Paula was waiting for my slides. I said, let me just wait and get the latest from CDC before I get the slides here. So we're up to over 1,000 cases of these basically extensive lung injury that's occurring because of the use of e-cigarettes. and we're up to 18 deaths, unfortunately. These are causing severe episodes of people very difficulty in breathing. And all these cases have been associated with an e-cigarette product. The other situation is that the products, as far as the types of products that are being used and what's in the product, there has not been as a single product that has actually identified itself as being the cause here. So there's an ongoing investigation. There's over 100 scientists working on this at CDC, and every state is launching their own investigation, working in coordination with CDC and FDA on this. So again, the information I want to refer to is this, which is excellent, the cdc.gov lung injury. You can go to that site. There's really valuable information, especially for healthcare providers in regard to understanding the diagnosis for these types of conditions, as well as the recommendations. So in North Carolina, what we've seen thus far is that we have 42 confirmed cases of lung illness. The majority of them male and young adults. Some of the symptoms are the same as we've seen nationally: shortness of breath, chest pain, nausea, vomiting, fever. Many of these people are in, obviously the case definition is that they've been hospitalized, most of them in ICU types of settings. And we don't know if this is going to be caused irreversible lung damage as well. I heard one physician quote that he felt like the lungs of a 19-year-old look like basically the lungs of a 70 or 80-year-old now. So there's obviously much chemical damage being done. There's some studies thinking that it could be related to an oily substance that's coming from the potential THC or something that's laced with. Mayo Clinic also has recently done some biopsies from autopsies from people who have died, and thinking that the lungs look more like chemical burn, really strong, almost like an environmental exposure. So we are still in the midst of a strong national as well as statewide investigation to find out what's happening. But again, THC being in the product as well as nicotine products. So CDC is really recommending that people obviously not do the same message we would have from a public health perspective, that they really try to stay away from these products, especially youth and young adults. Getting the product, especially from secondhand or other people, you don't know what you're getting. Pods are out there on the street that can be interfaced with Juul pods, for example. You don't know what you're getting in there with bottles of liquid that you refill them. You don't know exactly what you're getting. Another kid, for example, kids are trying to experiment with other types of substances like CBD oil and things of that nature. One kid which identified in himself is that he thought he was buying CBD oil, but was quickly hospitalized afterwards with intensive respiratory conditions. Found out it was basically a synthetic product. Didn't even have any CBD oil. So there's lots of different products out on the market. They're mislabeled. And CDC is also working through federal authorities to try to really track where supply lines are coming, where these products are coming from. So I want to really say a couple things that have happened just recently is that our state health director, Dr. Tilson, appeared in front of the House committee. This was a Energy and Commerce Committee. And I would encourage you, she was up there along with 3 other states. They were talking about the epidemic that we've seen with these lung injuries and illnesses. So I would encourage you to go and watch that, especially. It's very educational to see what the legislators are asking about and their cause for concern. So I want to talk, I've just listed a lot of public health concerns. So I want to talk really quick about some of the regulations that are coming. I want to end with just the problem itself. Let's talk about some solutions real quickly. So one thing I want to just point out is that the pre-market review and authorization, this has come back up now. FDA had punted this down the road for a while, but with this growing epidemic that we have among youth and young adults and the new emerging lung illness epidemic, FDA has come back to address this, to put this more on the forefront. And you also potentially saw an announcement on September 11th that, again, the FDA is going to work in the next 30 days to provide guidance to take the flavored products off the market. And then the companies will have to then go through a pre-market review to have their product put back on the market. So that's through that mechanism. I'll also say that we need to work on these solutions. This is an illustration I want to share with you. We're obviously in flu season. We're getting all our flu vaccines. This is my flu vaccine. This is a tobacco vaccine here. So these are the areas that we need to work on. Again, Steph's going to touch on the access to effective tobacco treatment, smoke-free, tobacco-free policies that I've mentioned, funding that's desperately needed, access, reducing access, raising the age to 21 to age to purchase these products, and hard-hitting media campaign. I want to just focus on the one area of state-operated healthcare facilities, a great example of working with doctors at those locations across the state to have them go completely tobacco-free and have a big focus on tobacco treatment, including e-cigarettes, a real highlight for our state. And we need to drill down and have that all happen at the local level as well, and that's a work in progress, obviously. We've been working a lot with our schools, quite significantly, because they're finding a lot of kids obviously coming with these products, trying to use them on campus, many because they're so addicted to the product. And so instead of just treating it as a behavioral or disciplinary action, we've tried to really focus more on treatment and helping these kids actually quit the product through treatment. So a lot of signs are going up across the state include that part of the policy for our tobacco-free schools includes e-cigarettes. Tobacco 21, as I mentioned, we're up to 18 states right now that have passed laws. It's something that we're looking into North Carolina, but we need to, if we pass a law here, we need it to be very strong in its wording. The Surgeon General, as I mentioned earlier, has termed this as an epidemic, and he has really valuable information on his website. Dr. Adams has really been a strong leader in our efforts to reduce this problem, and there's valuable information at that site. Truth has also developed access through the phones, which kids are welded to these days. So we're really trying to get kids to use their phones for cessation treatment. The Ditch Jewel number has been really another school-based and community-based program that's free. CBS Foundation is paying for this. It's a great program that focuses on e-cigs to educate kids more about the effort. Stanford Medicine has also got a great toolkit out there that you can download tremendous amounts of information that you can also provide in your clinical setting as well as a community setting. It's a great resource. We've been focusing a little bit on putting money into media, but we haven't had a lot of state money in order to do that. One organization we're working with is called Rescue, and what Rescue does is that, based on the science, is that they try to divide kids into peer crowds. They have 5 peer crowds, and you can see those on the screen. They feel like the messages that can get across to one peer crowd are different from the other peer crowds. And so the messages of looking at how to reach these kids, especially through social media, is very, very strategic. So we've been working on a small campaign, and we hope to widen that out. Their country campaign is called Down and Dirty. They take the lifestyles of kids that are in that country peer group and then incorporate tobacco prevention messages within that, especially through social media. Well, I'm going to end on a bad slide. This is what our funding has looked like, state funding. And so it dropped off. This is called what I call the cliff slide. In 2012, basically it went to 0. And we've been fighting by providing data and information to but we've seen very small numbers. The quitline dollars are still being sustained at the 1.2 million, but as far as prevention money, it's very, very tiny. So you'll get the slides later. These are our regional folks, which are great access and that can help with prevention and treatment. So I'll stop there, and while Steph comes up, if there's a question or so, I know we'll do some fast on a couple. Yes.
I just happened to see on the blue ad, the blue for the cigarette, there was actually a warning sign, but
Yeah.
I didn't see any in any of the other products, and you said that was still becoming like normalized. in some
FDA is
degree.
requiring a warning label
Wow.
on there at this point in time that specifically talks about that nicotine is addictive.
Yeah.
And the hard part about that is that kids don't understand addiction. They have no clue in regard to that they would become addicted to this product. The basic data that clearly shows that is that if you ask youth who are cigarette smokers if they'll be smoking in 5 years from now, basically 5% say they will, And in reality, you go out 5 years and 95% are still using it. So they don't understand that nicotine can be highly addictive. And so that's a message I'm not sure is quite getting across to the kids, but we're hoping to work on stronger messages down the road.
And I will try to leave time at the end of my presentation
Yeah.
for more questions.
Yeah.
And
We'll
then
transition.
we can talk about treating e-cigarette use as well as some of these questions of youth and prevention. Okay, so supporting clients to become tobacco free. First, I just want to take a moment to highlight specifically looking at the population that we serve, the behavioral health population, right? So we saw some of the rates earlier, but in the behavioral health population, the rate ranges from 32% to 98% who are using tobacco. And what I'll say is having a mental illness is also raises the likelihood that you will use an electronic product as well. I have feedback maybe. Is yours going?
Yeah.
And this higher number, that 98%, that's going to be more like the population that we serve, those with a co-occurring substance use disorder. So then if we take a look at our chart here, this is national data, we see that all these behavioral causes of death, HIV, homicide, alcohol, motor vehicle accidents, suicide, drug-induced, so overdoses, right, and obesity combined don't equal the number of people that die every year from tobacco. But if we take a look at the line with the star in our chart, we see that the number of people with a behavioral health condition that die, behavioral causes of death every year. So when we say that someone with a co-occurring tobacco use disorder and behavioral health condition might be more likely to die from their tobacco use than they are from the behavioral health disorder, that's what we mean. And then we have another, so Jim was talking about bad sides, this is another one, where basically we see that the prevalence of smoking is decreasing for those reporting better mental health, but it is not decreasing in a statistically significant way for those with poor mental health. So our light gray band here, only 2 of those years has a star above it, and those are the years where it decreased in a statistically significant way, the level of tobacco use in the population. So something that we're doing, all the things that Jim mentioned about policy and stuff, as well as the tobacco control vaccine, all that stuff. Something that we're doing is benefiting the people with better mental health, but it's not getting to people with poor mental health. Yes, the overall rate amongst people with poor mental health is higher, but also they're not benefiting equally from the policy and treatment that's out there. And so what do we know? Well, we know that there are actually a lot of positive effects on mental health from quitting smoking. The effects of quitting goal 2 are larger than those of antidepressant treatment for mood and anxiety disorders. That's from a meta-analysis from 2011. So I would think if you have a patient that's prescribed antidepressant and it's working for them, then we would want them to take it. We want them to help them adhere to it for equally as well, quitting smoking. And then there's no published evidence to support the hypothesis that quitting smoking is harmful to the mental health of people with schizophrenia. This is something that is a myth that was propagated by the tobacco industry with fake research in the past, so sometimes people ask me about that. And then continuing or starting to smoke actually increases the risk of returning to substance use after treatment. And that's from a meta-analysis from 2017, and then there's an even older one where they took a look at smoking cessation interventions and addictions, and they were associated with a 25% increased likelihood of long-term abstinence from alcohol and illicit drugs. So if we really want to provide evidence-based treatment for substance use disorders, we need to hit all the substance use disorders, right, including tobacco use disorder. And what I'll say is one thing that we do know is that people with a co-occurring behavioral health disorder do require longer and more intensive treatment for their tobacco use disorder. So that may also be responsible for some of the disparity that we saw, right? And then people with behavioral health disorders do want to quit. Motivation to quit is similar in the general population as those with mental illness, where more than half are interested in quitting. But those who are entering addictions treatment, they've done surveys that have documented between 44% and 80% are interested in quitting. So even if it's that lower number, who are we missing potentially by not offering evidence-based treatment to all the clients that we identify that use tobacco? And so then we have our last question. Are we addressing tobacco use disorder? I can say, folks with behavioral health conditions and behavioral health providers have been exposed to tobacco industry marketing and influence on society. I mentioned the fake research that they had put out there with schizophrenia. We saw many of the ads that Jim had. There are ads also for e-cigarettes that are like, relax with my blue. What is that getting at, right? Anxiety, stress, trying to attract people who are vulnerable. But at the same time, in my career, I've heard all of these statements about treating tobacco use in someone with a substance use disorder. He needs to quit drinking first. Smoking is the least of her problems. You're getting upset. Why don't you take a smoke break so you can calm down? Anyone heard that one? I see a few. I heard murmurs, yeah. So this is still out there, right? So are we surprised that this disparity exists, right? So nationally in 2015, about 70%, again, for folks with substance use disorders, maybe they're just getting back to seeing a physician because they go into treatment, right? So they might not even be in this population. Only about half of cigarette smokers were advised to quit. And fewer than 1/3 of smokers who tried to quit received evidence-based cessation treatment. So this isn't just people these are people who were in the action phase, right? They actually tried to quit, right? They weren't just contemplating or pre-contemplation or whatever it is. They actually tried to quit, but only 1/3 actually received evidence-based treatment. And then less than half of substance use disorder treatment centers, 42%, and offer tobacco cessation services, and only 34% offer cessation counseling, and that's from SAMHSA, and hopefully that number has improved a little bit. But by providing tobacco use treatment as part of your work treating substance use disorders overall, you're still very much on the cutting edge, right? And we saw all the benefits down the line for folks. Sometimes I get this question, do clients need to be ready? I think there used to be this idea of hitting rock bottom in substance use treatment, and that the person really needed to hit that in order to genuinely engage. That, of course, is not evidence-based and has been done away with, and the same is true with tobacco use. And so sometimes we will ask questions like, okay, do you use tobacco? Treatment is, and it doesn't, we would have the conversation hopefully with the patient about that, right? About engaging them in that and figuring out how we can get to a point where we are making some lifestyle changes. And we certainly wouldn't forget about it. Oh, they said they weren't ready to deal with their diabetes at the last.
Yeah.
I guess we'll get to it. All right, or maybe never. So that was the other piece that I want to say here too. Sometimes people say, well, what is the order? What is the priority? When is the right time to treat tobacco use in a client with a substance use disorder? And to that I would say, when the client is in front of you. Because you might not get another opportunity, and they're not getting it elsewhere. They're not getting it at other programs. They're not necessarily even getting it at their primary care doctor visit. We saw that only 1/3 received evidence-based treatments of the ones that tried to quit. So this is your shot to give them evidence-based substance use treatment and also to give them evidence-based tobacco use treatment. So what are our public health guidelines? Tobacco use disorder is a chronic relapsing condition, and effective treatments do exist. And all tobacco users should be offered treatment. This is our North Carolina tobacco treatment standard of care that we promote through our Certified Tobacco Treatment Specialist Training Program and also from our Division of Public Health. And basically saying that counseling, a combination of counseling and pharmacotherapy are the two most, the evidence-based treatment for tobacco use disorder. Not too surprising, tobacco use treatment is nicotine patches, that's the long-acting nicotine. And so the two most effective pharmacotherapies that give the person the greatest likelihood of becoming tobacco-free, given the exposure, are either varenicline, also known as Chantix, or 12 weeks of combination therapy, which is nicotine patches plus gum or lozenge. So sometimes folks haven't maybe necessarily had that in combination, they've only had one or the other. And this is the 5 A's of tobacco use treatment. This is the brief intervention for tobacco use treatment, right? So for those of you who have done like SBIRT, screening, brief intervention, referral to treatment, I see some nods for people who are familiar with that. I don't know why it has to have a different name. It's the same thing, screening, brief intervention, referral to treatment, the 5 A's. Ask about tobacco use, right? We're screening, advise folks to quit, assess their readiness to make a quit attempt, but we don't want to necessarily have that assessment of their readiness change whether or not we offer them evidence-based treatment, right? We don't want to stop it just ready to quit, no. Right. Assist with that quit attempt and arrange for follow-up care. So what are some tips for making your 5 A's count? Well, we want to make sure that we have a system to ask everybody, and we want to make sure that we're asking the question in an evidence-based way that people are likely to answer. How frequently do you use tobacco, right? It's a kind of a foregone conclusion that they use tobacco in that question. They can say never, right? Have you used tobacco products in the past? How frequently do you use an e-cigarette, a vape, Juul, or hookah pen? If I said to you, do you use a search engine? You have to think for a second, right? But if I said to you, do you use Google? You'd be like, yeah, I use Google. I know what Google is. It's the same thing with all of these vape products. It can be useful to kind of say, especially since, as Jim was saying, Juul has 70% of the market share for young people, to just name that, right? And so make sure that everybody knows what we're talking about here and that you're likely to have, that you're catching folks who are using. And if you think about this crisis and how they've had to go back through medical records and look to see and try to figure out the lack of assessing for this and the lack of documentation for this, could be a serious issue. So we want to make sure that we are documenting this, that people are using e-cigarettes. So some EHRs don't necessarily have a great way to log e-cigarette use. As for those of you, I know still there are many behavioral health organizations changing their EHR or moving to a different EHR and connect to the HIE system. So make sure that they have a good way to log e-cigarette use as you think about that. Having standardized questions is important. If you're having a medical assistant ask the question, how are they asking it? Are they saying, you don't smoke, do you? I've heard it. I've heard it in a medication-assisted treatment program I worked in. More likely than not, they do smoke, we know, right? And useful to mention types of brands as well. So people advice, we want it to be clear, strong, and personalized. It's easy to give strong advice. It's easy to give clear advice. It can be hard to give personalized advice. Clear and strong advice might be, well, you don't want to die, do you? So quit smoking. Probably not super helpful. Maybe will engender some resistance on the part of the patient. But tempting to say, right, given all of the terrible statistics that we've shared. But how about you really value recovery? One of the best things you can do to be successful is quitting smoking. That would be a really different message for someone to hear in a substance use treatment program and from a substance use treatment provider, that actually this isn't going to hinder your recovery quitting, this is going to help your recovery. This is going to make it more likely that you'll be, not have a return to use in the future. If that's what the person values, let's see the top one here. Playing with your grandkids is really important to you. Becoming tobacco-free is the best thing you can do to maintain your health so you can keep up with them. Okay, so then assessing motivation to quit. We're going to use our motivational interviewing skills. We're going to see whether importance or confidence is low, and then that kind of changes the discussion, right? If it's confidence and they've tried a bunch of times to quit and they just don't feel like they can do it, maybe we can talk to them a little bit about what I've seen work, for other patients, or what, the evidence tells us works. Would you be interested in talking about that? And then the importance, right? Finding where the tobacco use, e-cigarette use, conflict what the patient values. If it's money, if it's their health, whatever it is, where is that conflict for the patient? And developing that discrepancy, right? This is like a little classic sort of motivational reviewing chart, reasons to stay the same, reasons to change. If you go through these questions with your patient to kind of get to know them and their tobacco use, you'll hopefully find some of the areas where it is in conflict with what they value. And so this could be a useful little tool to use or to think about to guide the conversation so that you go beyond, do you smoke? Ready to quit? No. Okay. Right. And then assist. We want to prescribe or recommend or advocate for evidence-based medication. I mentioned earlier some of the information about medication. And we want to set some specific goals, like I'll start my medicine on Wednesday, or I'll make my car tobacco-free. Just because someone doesn't want to set a quit date we don't want to take that as them not being motivated. They may have other tobacco-related goals. So how can we just get a tobacco-related goal onto the treatment plan, right? How nicotine works. Ooh, do I have time for this? We'll go through it really quickly. So basically, we wake up in the morning, our y-axis is the level of nicotine, our x-axis is time. The first thing that we do if we use tobacco or vape is probably vape or smoke. I should change this to say vape or something to make it be more with the times. But we smoke, the level of nicotine shoots way up in our brain. We feel our reward, we feel our dopamine, and then during the day, of course, it goes back down, so then we smoke again, up, down, all day. How do people feel when they have to go a long time without smoking, without vaping, whatever it is? Anxious, irritable, all that kind of stuff. Depressed mood, feelings of frustration. We know the drill, right? So we know what's really happening here is we know that it's withdrawal symptoms, and then we're smoking. And so I bring this up to say that sometimes patients will say, I can't quit right now, it's too stressful, I have too much stress that's going on in my life. I need to tackle these things one at a time. And so going through this kind of process with patients, I've actually done this kind of little graph in a group as part of psychoeducation, right? And this is useful for any drug, right? You have your withdrawal symptoms, and so an addictive drug creates its own stress by creating these withdrawal symptoms that now you have to deal with through smoking or other means, and so it actually creates its own stress. It's adding to the stress in life, and that's why we see partly that people's mental health improves when they quit smoking, because they get off, they have an off-ramp from this trauma, up and down, all of it. So just kind of raising folks' awareness of the effect it actually does have on their mental health, not just their physical health. And we have 7 first-line tobacco use treatment medications. And I wanted to just note, sometimes people ask me, Jim mentioned this earlier, Juul, and also the products that are like Juul, have a higher level of nicotine, and the puff pattern, the inhalation, and that level in your brain mirrors that of cigarette smoking. And then this is our comparison of that same thing, but with medications. So the red line is nicotine coming from our nicotine patch, the green line is from the gum. So you can see none of them actually hit that point as quickly of nicotine as cigarette smoking, which is our blue line. And so that's where we see that the medications are not addictive, right? It's over a longer period of time, it's not as quickly, not hitting your brain as quickly, and it doesn't quite equal that amount. And that's why we say, put the patch and the gum together. All right, so our standard of care, I mentioned this about medications. One thing to think about with the assist with e-cigarettes is we definitely do want to prescribe tobacco use treatment medications, and 1 Juul pod could be between 1 to 2 packs of cigarettes, as Jim mentioned. Could try assessing use prior to initiating e-cigarettes of dual user, but given some of what Jim was mentioning about the addictiveness of it, some people do find that they use more, right, with the e-cigarette, so that might not always work. It's just an ongoing process to assess their withdrawal symptoms and make sure that they're adequately treated, because we know if they're not adequately treated, people will be very likely to have a return to use. Varenicline is a good option because the dose is not based off of nicotine matching, so if you don't know how much nicotine the person's getting, you could go to Varenicline as an option. And for follow-up, it could be that you're providing treatment hopefully in-house, but also you could be referring folks to the North Carolina Quitline. And I want to just touch briefly on that. Our Quitline is available 24/7 in English and Spanish all day. We do triage services to those who need it most because we do have limited funding. As Jim was saying, it was great that our funding was steady there, but it's not enough to meet the demand for tobacco use treatment in North Carolina. And so we try to get it to folks who don't have access, like those who are uninsured, with Medicare and Medicaid. Contract with the Quitline to provide services as well. And for those who are commercially insured, they receive 1 call. So they can at least come up with a quit plan and receive evidence-based information. So totally still refer them, but they're not going to get ongoing quit support from that quit coach unless they have Blue Cross Blue Shield. And I'm gonna have my contact info at the end, and we're gonna share these slides, but I can email like a summary of services of exactly what the level is so that you can know when you kind of talk to your patients about what they could potentially get. And I wanna highlight here too, for those with 1 or more behavioral health condition, they receive 7 calls and get 12 weeks of nicotine patches plus gummer lozenge. So they receive the highest level of treatment. They share that they have that behavior and mention that it will affect their ability to quit smoking. Does the Quitline work? Our bottom line here is from the state health plan when they provided counseling and combo nicotine replacement. So that is, all people with private health insurance, so we do see a little bit of a higher quit rate there, but yes, absolutely the Quitline is evidence-based and does work. And then I mentioned the thing, so before we instituted that behavioral health protocol I mentioned, our quit rate amongst the population that we serve was lower, right, 19%. But with the behavioral health protocol, the 7 calls, we see that in other states that have implemented it, a quit rate more like 37%, 6 months out. So really trying to address that health disparity. And how do we get folks to the Quitline? You can send a fax referral, or if your EHR can fax refer, I can talk to you about that and talk to you about how to set that up. But basically, this is available on quitlinenc.com, our website. And you can have the patient fill out their information, send that off to the Quitline via fax, and the Quitline will call them, rather than you just giving them materials and saying, I hope you call. I hope you get to substance use treatment. We know that that's probably not the best way.
So we could do that with people before they leave the office?
Yes, absolutely, and you should. And hopefully that's that's good. And then you get outcome reports. You receive, did they quit? Did they set a quit date? Not did they quit, because actually the outcome report is just their enrollment, and did they set a quit date? You can choose to get an additional outcome report about the program for teens, to help teens quit. And Jim mentioned it earlier, but you can actually print, like we can email you this art and you can print your own. We don't have it printed to give to you like we do in Quitline materials. If you work with teens, I think this is great. Or if you just, the team can text it, nobody knows, right? And we are at time here, so I'll just say one last thing. There's one more thing that makes it tough to quit. Cases seeking behavioral health treatment means exposure to tobacco use, right? If we don't have a tobacco-free policy in the setting where we serve our clients, it's an environment that is, hostile to their recovery from tobacco use disorder, right? And so if we want to see all this great 5 A's work, if we want our referrals to the Quitline to work, if they keep coming back to our environment to see us where they're being triggered to smoke all the time, that's a very tough road to hoe, given that they are, have that co-occurring substance use disorder as well. So we're asking the folks that need the most treatment, have the most difficult time quitting, to also then be in these environments that are triggering them constantly to use tobacco. And our regional managers, as well as myself, are available to help folks implement tobacco-free policies. So I'll open it up to questions.
I have a general question for one of the two speakers, as it relates to teenagers. How do they obtain the Juul? I assume they ordered it online. That's question one. Question two has to do with how much the Juul apparatus costs and how much these flavor pod costs. And then question three is this state taxed like cigarettes are? Because in the states that had high state tax rates on cigarettes, smoking levels were lower. And that's probably one of the most important things. So I don't know the answer to any of those.
Let me address those three quickly. The first question is access to the products. Often they're buying from retailers. We're trying to beef up, in our state, we're trying to beef up our efforts to make sure that that retailers are not illegally selling these products to anyone under the age of 18. But one thing that also often occurs is that seniors who are turning 18, about a third of seniors turn 18 during their senior year of high school, are actually going out and purchasing large quantities of Juul and supplying them to their friends as social sources, either selling them or providing them in some way. So that's another rationale point and strong point to raise the age up to 21, so that we at least take that scenario of social sources out of the high school setting. As far as cost, the Juul, the starter kit, so you get the device itself, which is rechargeable within your computer. It has a USB, so you can just stick it in the computer and recharge it. And then it comes with 4 pods in the starter kit. That's been advertised. It was retail at $40. But competitors have been coming on the market, so Juul has reduced that down for it. The pods itself are $4, and that's about $20, but there's also discounts for that as well. So anyways, the pods, if they're equal to 1 or more packs of cigarettes, they're actually ends up being a little bit cheaper than a pack of cigarettes. As far as the tax itself, our state is one of a few states that taxes e-cigarettes, but the way that our product is taxed was based on the recommendation that the industry gave to the legislature on how to tax in our state, and that's 5 cents per milliliter of nicotine solution. We are the lowest tax state, one of the lowest tax states for cigarettes in the country, and equivalent, this would be even lower. So we're, in comparison to other states that have actually taxed the product, it's much higher. But still, that's an area where many states are looking to address this issue.
And there was a question.
Yeah.
Yes, I had a 12-year-old come in that is just vaping the flavor itself. And so we had to have a discussion because she doesn't feel she's addicted because she's not using the tobacco product, just the flavor.
I think the question would be, how is she getting a hold of just only a flavored product? Because it's probably mislabeled if it's only listing a flavor. When there's been products out in the market that have been listed no nicotine, but when tested in the lab, nicotine shows up at a high level. So kids are often misperceiving what they're actually inhaling into their body. And most kids do feel like they're not on a Juul. Most kids did not identify that nicotine was in the product.
Mm-hmm. And she had been doing it since she was 11. So just to let you know.
Mm-hmm.
Yeah, I would assess her for, just I mean, and I'm sure you probably did, for withdrawal symptoms. And we could talk more about a lot about it.
Yeah, you might want to support
Yeah.
actually the type of device that she's actually using.
Yeah, right, exactly.
Are you guys hanging out afterwards?
Yeah.
Okay, you guys can hear from them
Any
again.
questions? Sure.
Thank you.
If there's something we get questions about as a student whenever we are planning conferences, it's always tobacco and vaping are always on the list. So thanks for the really good presentations on that and catching this up. Everybody wants to stand up for a minute. Just stand up. Take a deep breath. And do a little surfing. Feel free to stay standing if you would like, just don't leave. So our last presentation for the day is going to be, take a little bit of a detour, but I think a useful one, and that is to look at so-called behavioral addictions. And that, you know, the things that also are called, often referred to as process addiction, behavioral addiction, you know, an attempt to talk about compulsive behaviors that have an addictive character but don't involve a drug. And there's a long list. The list gets longer as the internet comes up with yet another variation and whatnot. They really cover a lot of territory. And so trying to talk about these, the discussion's been going on at least 20 or 30 years. I think one of the earlier articles I reviewed in preparing for this was from 1990. It's really been an active discussion, and it's still actively going on. And so what I'm going to do for this presentation is I'm going to try and bring folks up to speed a little bit in terms of what are some of the recent changes, categories, diagnostic categories of the DSM-4 and the ICD-11. Get into background concepts and terminology a bit. You know, Dr. Franken mentioned, you know, the important role of impulsivity in a whole range of dysfunctional behaviors and potentially problematic behaviors. And so one of the really interesting things about putting this lecture together was really starting to take a bit of a dive into this. What do we mean by impulsivity? And what do we mean by compulsivity? And what are the underlying principles and how they overlap with others and whatnot? So we'll get into that a bit. We're not going to get too far because it's a rabbit hole, to be frank about it. And it really goes a lot of different directions. But I want to at least get into concepts and terminology enough to sort of enable some of the discussions that we'll be having with patients and with other colleagues. And as we're thinking about what are these disorders that we're considering naming as addictions. And if you recall from the discussion this morning, that means, are they diseases? Or do they fit the same sort of categorization that we would use for substance use disorders, addictive drug disorders? And so we'll after we do the concepts and terminology, we'll get into a bit about what's the same and what's different. We'll highlight some of the common behavioral addictions. And then the thing I really want to make sure we get to is recommendations for practice. Okay, so it's fine to get into sort of theory and ephemera and rabbit holes and whatnot, but what does that mean on a day-to-day basis for us as patients, as we're seeing individuals and their families? One of my favorite quotes I came up with: life is a series of addictions and then we die. Of course, it's a British physician making that comment. The British literature always has more of a tendency to allow humor in their publications. And we'll come back to this actually a little bit later, but right now it's just leading in on this idea of we've got this valid, normally, are functional or even necessary. And I think that's going to be a dilemma that we're going to face as we talk to people, as we try and establish diagnoses, as we try to establish where are people on these continuum of behaviors. Because a lot of these things are things that people need to survive, to live. Meaning bound to or enslaved by, does this qualify? When do normative life-sustaining drives, food, work, sex, or life-supporting behaviors, shopping, internet use, become pathological? When do they become diseases? And when does need or want become craving? And why should we care? Why is this important? Are they even treatable? And how common are they? So how much time do we need to spend on these? Well, one of my favorite articles about prevalence was prevalence of the addictions, a problem of majority or the minority. And this was a study where they looked at 83 studies, all within a 500 or better. So this is a lot of people. And they did screening for and interviewing around not only substance use disorders, but also a lot of these process addictions, gambling, internet, sex, exercise, work, shopping. And they found a total prevalence of 61%. If they took out the substance use disorders, just the process addictions, behavioral addictions, was 46%. And so their summative statement was, it's plausible that 47% of US adults suffers from maladaptive signs of addictive disorder over a 12-month period. Is this a problem of the majority or the minority, if it's that common? When another study looked at the natural history of these and looked at them over a 5-year period of time, they asked, how over-involvement in a particular behavior has over-involvement caused significant problems in the past 12 months. In other words, sort of a screening question about this. The large majority demonstrated over-involvement for one behavior during any given period. That may be a different one this year, another one that year, but at any given time, a large majority evoked that yes, there was one of these things that they thought was causing problems. But each of those behaviors tend to decrease in symptom severity over time, and help seeking was low, eating and exercise. So the conclusion was that for most, these disorders are typically transient and non-progressive even without treatment. So if we're screening, what that says to me is if we're screening for this, we're going to find a lot of people that have these problems. Which of those people need help and need treatment will be a different matter, and which of those who want treatment will be a different matter. If we look at studies that look at actual prevalence, like where they're really bored down and said, okay, what's those throwing in an idea of prevalence of not just do you think you have a problem with this, but people who meet diagnostic criteria. And you can see that the results range anywhere from 2% up to 3 to 6%, and with work and gaming being somewhat higher. But these are not inconsistent with what we know about most substance use disorders. Most people do the activity, use the drug or whatnot. Some people get into trouble with it, but a relatively small percentage actually get addicted to it. When we're talking about these kind of prevalence studies, it really gets tricky because there aren't a lot of validated instruments. A lot of studies sort of conflate problematic and severe, so it's hard to tell exactly what they're talking about. And then also, it depends on how they chose to do the survey. If you do a survey for internet use disorder, and it's an online survey, it's going to be a little skewed. There are clearly gender issues involved and culture issues that we're still trying to, experts are still trying to sort through. So there are certain things seem to be more common in men, some more common in women, some within certain subcultures or within national cultures. So what's changed in terms of diagnostic categorization? Well, the DSM-5, 2013, pulled a really interesting, resolved this in a really interesting way. They basically created a new category, substance-related and addictive disorders, and put substance use disorders in it. Substance use disorders used to be their own category. Now, substance use disorders is put in substance-related and addictive disorders. Gambling was thrown in with that. Now, gambling had been in the DSM-4, but it was an impulse control with the addictive disorders. And they also said that internet gaming has plenty of research, not quite enough to qualify, but it's worth study, and most likely it's going to be included in the next go-around. So the thing that's kind of interesting about this is why isn't it substance-related and other addictive disorders? So, you remember that slide on the DSM-4 categories? Gradually addiction was thrown out the window because it was considered to be stigmatizing and pejorative, and so we went with things like substance abuse and substance dependence, and then now we're with substance use disorders. So we kind of got rid of addiction because it was too pejorative, but now we put it back in with substance use disorders, but decided substance use disorders aren't really addictions, it's substance use related stuff and addictions. But they're all under the same umbrella. So if you're looking for the most ironic statement in the presentation, you can stop listening, because that's now it. I really struggled with that for a while, but I've kind of come I'll comment later on why I think that's actually not a bad idea clinically, because even though, and I'll go right to the punchline now, it is really important that we be careful about stigmatizing terminology when we're dealing with folks with substance use disorders and addictive disorders. And so getting rid of that terminology when you're talking with someone with a drug addiction potentially has the benefit of sort of destigmatizing what they're dealing with. If you're talking with someone with a behavioral addiction, who mostly what they think is, I just got this bad habit. I just got this behavior I can't change. So you start referring to it as an addictive behavior, and it allows them to say, oh, okay, now I can kind of see why this is out of control and whatnot. So I actually, even though I came close to calling a number of people, saying, why the hell did you do this? I ended up thinking, no, not a bad idea. Okay, so those are the ones that have gone into the DSM-5, but what about all the other behavioral addictions? And all of these were presented to the committee, all of these were advocated for, all of them were dismissed as not having adequate research. Well, what about all the other compulsive impulsive disorders? OCD, kleptomania, pyromania, trichotillomania, skin picking, picas, nail biting, hoarding, and oh, by the way, Benjamin Rush's decision that pathological lying really should be in here too. So what about all those? Well, just to keep in mind that some of the things that we're kind of wrestling with as addictions are already in the diagnostic categories, right? So hoarding, for example, is now considered an OCD and related disorder. So one of the things that DSM-5 did is they took OCD out of anxiety, gave it its own category, and then lumped in some related things. Eating disorders, particularly binge eating, is already in there, except they took eating disorder, the category, and renamed it eating and feeding disorders. And they put binge eating disorder not needing purging or over-exercise, just binging on food without throwing up or overcompensating with exercise as a specific disorder. And they added feeding disorders like pica and rumination. Okay. So some of those things that we're talking about as behavioral addictions are in the DSM-5. They're just under different categories, and they're lumped in with all this range of impulse control disorders. And oh, by the way, the ICD-11 is coming out, and ICD-11, which has an impulse control category, which has had gambling disorder for a while. They added gaming disorder and compulsive sexual behavior disorder. So even though DSM-5 turned down those two as not having enough evidence, ICD-11 said, no, there's enough evidence, let's go ahead and put them in this diagnostic category.
I knew they'd be there.
So let me hit a couple of core concepts, a couple of things that as I kind of pursued this, and a point of disclosure, I by no means consider myself a behavioral addiction expert. The whole full disclosure on this is Sarah and I are planning the conference, we're trying to find somebody to talk about behavioral addictions. We were struggling to find someone, and I said, I'll do it. I really need to know more about this, so let me go ahead and see if I can research it and put something together. So for me, part of that was then figuring out, okay, well, what are we talking about when we talk about impulsivity, compulsivity, addiction, and whatnot? So impulsivity and compulsivity both refer to an inability to resist an impulse or show inability to refrain from repetitive behaviors in spite of potential harm to self or others. That is, they show lack of control around that particular behavior. And traditionally, they've been put in a particular framework that I ran up against time and again, and they're often seen as two ends of a continuum, with impulsivity being driven by an effort to obtain arousal or pleasure, and being facilitated by an underestimated perceived risk. So this person does this sort of risk-benefit analysis in their head. They're looking for pleasure, they're underestimating the risk and saying, boom, let me go ahead and do this. As opposed to compulsivity in the psychiatric literature is generally thought to be driven by an effort to reduce anxiety or dysphoria, a negative mood state, and it's facilitated by an exaggerated sense of potential harm. So if you think of somebody with OCD, obsessive compulsive disorder, they're really feeling this sense of unease, and they have to do this compulsive behavior to try and lower that because they have this sort of exaggerated sense of harm. If I don't fold the towels 5 times, my kid's going to die, or whatever the sort of associated thought process. Now, the other concept that is sort of interacts with this, interestingly enough, is one of the other interesting things in the DSM-5 is that it really started emphasizing different behavioral spectrum. And so there's an impulse to spectrum, there's an anxiety spectrum, there's all these different, but one of the spectrums is a focus spectrum. How focused are people? One end is ADD, people that have really a hard time focusing. The other end is hyperfocus, and that's sort of obsessive compulsive, where people just can't let loose, they can't let loose of the particular thought or thing that they're focusing on. And so I thought I'd try and make sure that I could give you a good example so you could keep this in mind. So I'm going to start with a clinical example.
No, we don't.
We just went through the drive-up window. What did we get, Cooper? Daisy, what did we get at the drive-up window? No, Cooper. Let Daisy have some. No, Cooper. Daisy, where did we go? Did we go to McDonald's? No. Daisy gets hers first. Why does Daisy get hers first? Because Cooper.
Okay. So impulse, for some reason, I want to dance. Do I need to do something to... Well, it worked. For some reason, it's not. Maybe it wants to stay stuck on that. Okay, so that's impulse control disorder, and I think, what do you think would have happened if that had been a gallon of ice cream?
Same thing.
Right. So what's your working diagnosis? I'm going with binge eating disorder. I mean, we could call it impulse control disorder, not otherwise classified, but hey, come on. So my second canine consultant, Birdie, many of you may know Birdie is a therapy dog that we have in our practice. As you can see, he's a conscientious professional, well-behaved. He's even got that look that therapists sort of cultivate, that sort of, you know, interested and actively listening, but also a little aloof, you know. And so, responsible guy until you take him on a walk and he's triggered by a particular smell. Right? He goes into hyper-focus mode, escalated craving, absolute compulsion. Note the body language. Note the tension on the leash. He will keep his head down that hole until I pick him up and move him. Okay? So, impulse control disorder, hyper-focus compulsion, 2 ends of the spectrum. Now, people that like to work with people and talk about people usually put, again, these sort of disorders on this continuum, and they go from the compulsive end, anxiety relief, exaggerated harm, and the impulsive end, arousal, pleasure, underestimated risk. And the thing that's kind of interesting about this is if you notice where most of the behavioral addictions are and the substance use disorders, they're kind of in the middle. And so as much detail as the psychiatric literature goes into making a distinction between these two, if you think about folks with behavioral addictions and or substance use disorders, mostly what you see is a combination. Who hasn't heard somebody say, God, if somebody puts cocaine in front of me, there's no way I can't use. Boom, it's gone before I know what I'm doing. There's no distance between the thought or feeling and the action. Right? On the other hand, one of the students and I were sitting with a patient a week or so ago who described that he was alcoholic and he had periods of sobriety and he'd stay sober for a month, 2, 3 months at a time. He said, but you know, I thought about it every day. Great. Couldn't get it out of my head. So I think you know, in terms of when you're talking to people and they use words like impulse and they use words like compulsion or obsession or you're thinking those things, just think about the behaviors and what that means, and listen for it. And you'll hear people describe those things as they talk about either the substance use disorders or these other behaviors we're going to talk about. So that's concept number one. Concept number two, I'm only going to skim over a little bit because it's very complex and it's underneath what Dr. Prakken talked about earlier when he talked about how there are these impulsive behaviors that seem to cut across all kinds of things. And sooner or later we're going to discover something that ties it together or whatnot. Okay, so there are a lot of folks that are looking at what are the components that facilitate impulsivity and compulsivity in terms of cognitive and behavioral domains. What is it about the way people's brains are wired? What is it about their sort of behavioral repertoire that leads them to be more susceptible to this? And the thing that I think is profound about this, and it's since things, some of which I understand, some of which I got to, read more about, but sensitivity to reward delay. How good can you tolerate not being rewarded immediately? Your risk-reward decision-making, the premature anticipatory, almost said premature.
You did! I heard that.
I don't think it's that far off. Premature anticipatory responding, perseverative responding, that is getting stuck in the same loop and keeping wanting to respond the same way even though the stimulus is different, etc. So there's clearly, I think in the first talk I talked about this continuum from volitional or voluntary self-control through habitual and then on to impulsive and compulsive and then out of control, right? Well, this is talking about, is there such a thing as voluntary volitional control? Is there such a thing as, oh hell, if we go too far down this rabbit hole, we end up in Geneva debating Calvin about free will. But, to what extent are we wired to where the first time anytime we're making a decision or a choice, it's pretty much preordained in one way or another by our ACE score, by our childhood attachments, by our genetics, whatever it is. Okay? And I think I agree with Dr. Prakken that sooner or later we might figure this out. Either that or we'll end up on Westworld as one of the hosts that's trying to figure out if their emotions are real and all that kind of stuff. I gotta tell you, I went there one night with this, so that's, okay, all right. So the other thing that's a very common dynamic around this is the co-occurrence of substance disorders with behavioral addictions. In other words, there's a lot of cross-pollination going on. A lot of folks that have these behavioral addictions also have substance use disorders. There's a lot of association between behavioral addictions and psychiatric disorders. So there's a lot of overlap there, and sometimes it's pretty dramatic. So if you look at, for example, gambling, that 4+ depressive disorders means that there's a greater than 50% correlation or overlap in multiple meta-analyses. So that's a pretty strong association. Or you go down to personality disorder along the bottom and underneath buying, and there's a compulsive buying and shopping. There's a real high correlation there, etc. So there's a very high correlation among these, and so clearly, as Dr. Prakken said, there's something going on that's sort of tying into all of these things, all of these. And overlap. Can you see multiple disorders overlap in one individual, for example? Can you see someone who has limited impulse control, compulsive overeating, history of hypersexuality, history of gambling, compulsive overuse of social media, all causing serious problems for others, all within the setting of attention deficit disorder, personality disorders like narcissism and antisocial personality disorder. Oh, Jesus, how did that get in there? Scary. Scary. Now, some folks may take issue with me using that as a particular example of this set of characteristics, right? But I just saved, as an instructor, as a lecturer, I just saved 10 minutes of not having to describe all these behaviors. And I also set myself up to highlight a couple of other very important clinical issues around behavioral addictions and substance use disorders in general. And that is that there is this clear overlap between personality factors, neurocognitive framework, psychiatric comorbid behaviors we're looking at. And that a really important part of changing those behaviors is the person has to recognize that they're a problem. They have to have felt the negative consequences and or heard other people, you know, imposing on them the fact that these behaviors are problematic. And as a result of those negative consequences and their self-awareness, they decide it's time to change that behavior. And oh, by the way, that's really impeded if that person has the resources to avoid the consequences of the behavior, and or they have people around them enabling and facilitating and buffering them from the consequences. So I think it's really something that is one of the challenges that we have with all this, and I think that challenge gets even more pronounced when we're talking about behavioral addictions, where there's not this clear, you know, agent, there's not this clear toxic agent like a drug involved. It's all about somebody's behaviors. So are they addictions or not? You know, can they be pathological when they're seen as rewarding by the individual? They don't have an obvious marker such as the drug. And sometimes the behavioral indicators can be hard to sort out. But, you know, I'm going to pause here and I'll have a couple of slides to highlight it. We know these are problems. I mean, if we define them as an extreme set of behaviors that really do cause negative consequences, and yet the person doesn't seem to be able to control, we know that those are problems. And we know, and I'll go over some of the ways in which these things are more similar to substance use disorders than they're different. But in the meantime, I don't think we have to wait for the DSM-5 or anything else, to, you know, DSM-6 or whatever to come out and say these are addictions, these are categorical disorders. In the words of a Supreme Court justice some years ago in a well-known Infinity case, I shall not attempt to define hardcore pornography, but I know it when I see it.
And he was blind.
And it's, you know, of course, C has a double meaning, not to sound like Bill Clinton, another guy with some sexual acting out problems. You know, when we're talking about see it in terms of seeing it, in other words, being able to look at it, know what it is, and see it in a certain way, to interpret what you're seeing in a certain way. So, you know, if we do that, if we think about these in terms of what we already know, I think we can move on. So the quote at the beginning, life is a series of addictions and then we die, you know, again, what Dr. Marks was talking about is, you know, we have a series of compulsive behaviors built into us that are there to keep us alive. You know, so we have a craving or withdrawal from not having water, food, or sex. We obtain that, we get satiated, we get relief, wears off, we get craving again, withdrawal, repeat. And so we go through life with these constantly repetitive needs for something that we feel dysphoric when we don't have it, we get it, we feel relief. And so we've got this built-in reward system that is there to keep us alive. And what we're talking about with whether we're talking about a drug addiction or whether we're talking about behavioral addiction is hijacking of those reward systems. And the research is very extensive now about that in terms of drugs. It's accumulating in terms of a lot of these others. In particular, the data we have on that reward system hijacking is very clear with gambling, it's very clear with food addiction. It's evolving with a lot of these others, but it clearly seems to be a significant underpinning in a lot of these. And even this idea of, well, yeah, but it's a normative behavior and we need it to survive, and can that really be an addiction? Again, if we think back on the continuum model that we talked about earlier, we're talking about behaviors that can be quite useful, but at a certain point they get more problematic. At a certain point they get graying over into this, serious problems, negative consequences, and you can't stop. And they have clearly grayed over into what we would consider an addiction, or what we are perfectly reasonable to consider a disease. So, for example, how many atherosclerotic plaques do you have to have before they say you have coronary artery disease? So, every man in this room that's 50 or 55, whatever the American Heart Association recommendations are, should be on a statin. By definition, every man over 55 has early coronary artery disease until proven otherwise. And so, even with things like coronary artery disease, diabetes versus continuum. And in fact, the more I thought about this, I really think coronary artery disease needs to be categorized as a behavioral addiction that have diet and exercise and smoking. And of course, genetics is in the mix, but it's largely, coronary artery disease is largely a behavioral disorder with very serious negative medical consequences. So I don't think we're out on a limb at all to say just because these are behaviors and don't involve a drug, that that's not an addiction. So if we remember from the diagnosis, the talk about disease and addiction earlier, you know, the common common characteristics of addictive behavior: craving, using more than intended, unable to stop or cut down, continued usage by harmful consequences, possibly tolerance, possibly withdrawal, certainly salience, this preoccupation, this all, you know, your whole life gradually wrapping around a particular drug, and the use of the drug for mood modification. In this case, all of those things are in play. And so as we go through some of the disorders, just kind of keep that in mind as we think about them. So, as I said, gambling disorder is one of the ones that's got the biggest literature on it. It's the one that's been accepted into the DSM-5. And if you look at the criteria, it's basically based on the substance use disorder style criteria, but with gambling substituted when there's a reference to drugs. There's clearly some things that are specific and commonly seen in gambling: chasing one's losses, lying, relying on others for money, feeling distressed, going through phases of winning, losing, desperation, hopelessness. And interestingly enough, there's another thing that's common to, if you remember, for alcohol abuse in women, there's this thing called telescoping, where women tend to have the onset of alcohol use disorders later in life, and it telescopes. It gets bad really quickly. So women alcoholics often die earlier than men with shorter histories. That same phenomenon is seen with gambling. So women usually don't start gambling until later in life, but when they do, they get it worse quickly than men do. It's 82% of U.S. residents gamble in one way or another. Now, for most people, that's a non-problematic thing. 74 billion in gaming revenue. Problematic gamblers have an average of $40,000 in individual debt and involve 25 hours per week. So again, when you start looking at specifics, you really start seeing, okay, these are people that are really on an extreme end of the behavioral continuum. It's worth noting that even though those gambling casino revenues were really dramatic, they're falling, and they're falling largely because now there's access to online gaming and a lot of other varieties of gaming that don't involve going to a casino. So casino revenues are actually declining. And so what are the opportunities? What are the options? What are the different venues or top styles of gambling that the person's accessing and relating to? And that there's more and more of those, and with internet gaming in particular, gambling in particular, making it really accessible. The gambling, again, is one of the disorders, the behavioral disorders, that has the most data on it hijacking the reward system, the neurochemistry. It's very extensive, it's very clear, it's very well documented. That's one of the reasons DSM went ahead and took them under the fold. It's also very strong in terms of food addiction, eating. It's less so with some of the others. When you start looking at the literature and you're reading the articles and the chapters and whatnot, they'll talk about this effect on serotonin or that effect on dopamine or this effect on this reward system or whatnot. But it's not as clearly laid out. But most of the expectation when you read the authorities on it is sooner or later it is all sort of going to side. There are genetic aspects that have been pointed out with gambling. The second one, for example, there's a particular allele of a receptor gene that increases in frequency from non-problematic to pathological gambling and co-occurring problematic gambling and substance use disorders. So there's, they're sort of trying to ferret out, okay, if there is a genetic predisposition, what's that all about? There are distortions in terms of how people interpret their losses and keep chasing losses and whatnot. The sunk cost effect is a thing where you keep going, and somebody's going, aren't you going to stop? And you say, no, I put this much into it, I got to keep putting more into it. It's just around the corner, I'm going to win, I'm going to win. In the meantime, they're digging a hole into the center of the earth for themselves. Superstitious beliefs, selective memory, all these things were just sort of facilitating this pattern of behavior. Gambling is one of the few things I could find that had a simple screening tool. And at the end of this lecture, there'll be a couple of slides that have diagnostic instruments, screening and or diagnostic instruments that you can access online and download if you'd like. But this is one of the few where I could find two questions. Have you ever felt the need to bet more and more money? Have you ever had to lie to people important to you on how much you gamble? Great sensitivity and specificity for gambling disorder. There's a longer disorder. The instrument that I found that seemed to have the most validity among people that authorities was for a longer screen is the Massachusetts gambling screen that gets into more detail. And again, as we go through these, and we'll sort of flash a number of them up on the screen as we go along, they're all going to be more or less the same thing. They're going to be some variation of taking the DSM criteria, loss of control, dysphoria, using it for mood regulation, all these things, and putting their particular word in to analyze, is this behavior problematic and how problematic it is. There's pretty good evidence for gambling also that the therapies work, so there's good evidence that cognitive behavioral therapies applied to gambling do have successful outcomes. Family therapy, as you can imagine, is generally a part of that. There's Gamblers Anonymous, it's sort of the archetype for, along with Overeaters Anonymous, of a peer support group like AA that's expanded into these particular areas. And I'll come back to medication at the end. The second disorder that's at least been given conditions for further study is gaming disorder. And again, there's this increasing amount of time involved on internet gaming, and it includes other compulsive behaviors on the internet. In other words, it's later on we'll talk about internet use disorder, where there's somebody that's just online all the time, and gaming may be one of the things they're doing. But this is when internet gaming is the real focus. It's most prevalent in young men. Asian countries seem to be hit particularly hard. Massively multiplayer online role-playing is considered to be one of the most compulsive and addictogenic of the game disorders. It has team aspects that are considered a key motivation for involvement. The dark side of that is it's also notorious for shaming and bullying, and people that are really getting strung out on it are putting a lot of hours. And one of the reasons I wanted to look into this some more is to look at the other end of the spectrum. Is I have a patient that's in his 70s. He's retired. He's an alcohol-dependent individual and opiate dependent. And he came in, and then I said, "So, how's the painting going?" Because I know he does painting as a hobby. He said, "No, I'm not really painting." "Oh yeah, what are you doing?" "Oh, I'm really getting into gaming. The Xbox is my friend." "Oh, really?" So we talked about it. I said, just give me an average time you spending every day on the Xbox. "Oh, about 6 to 8 hours." Okay, I need to think about this a little more because I need to know how to respond to that. Now, as I said, the ICD-11 has now included gaming disorder, so they actually have criteria that they've developed in terms of who qualifies for gaming disorder. This can be online or offline. And again, impaired control, escalation, taking more priority over the person's life, continuous. In terms of gaming, it can be continuous or episodic, which is kind of the equivalent between a daily drinker and a binge drinker, for example. Okay. It has to be evident over the last 12 months, although that can be shortened if the symptoms are severe. And there's an online gaming addiction test, which I have on that. I have a link to at the end of the slides, which is a variation of the internet game addiction scale that Kimberly Young developed, which applies that particularly to gaming online, increasing amounts of time, preoccupied, lie to friends and family, restless or irritable when attempting to cut down, unsuccessful efforts to control, way of escaping dysphoric mood, that sort of thing. Now, the whole idea of internet use disorder is really up in the air as far as I can tell, because on the one hand, there's this question: are we talking about addiction to the internet or addiction on the internet? So somebody who has a gambling disorder that's gambling primarily on the internet, is that an internet disorder or gambling? And most people say no, it's gambling, but that's the venue. Same thing with porn, same thing with a lot of it was buying, shopping, auctions, all that kind of stuff. Is it the internet, or is it the disorder being acted out on the disorder on the internet? But I have to be, clear, the more you read about this, it's like there's something about the internet. So, poker versus online poker is kind of like marijuana versus hash oil, or porn magazine versus online porn. It's kind of like powdered cocaine versus crack. I mean, whether it's the immediate access, the multiple rewards, whatever it is, it really seems to facilitate some of these behaviors. And one particularly distressing example that's being publicized recently is pedophilia towards young children, which used to be pretty unusual. It's not like it never existed, but it was unusual. The estimate is there are now 45 million images of child sexual abuse online in 2019, and that doubled from 2018. And that doubled from the year before, and on and on. So there's something about this that really is addictogenic in a really difficult way. Kimberly Young is one of the authors that's been working in this area for a number of years, and a lot of whenever you go to the literature and you go looking at screening and whatnot, her materials will come up a lot, and so she has a well-regarded screening instrument for internet addiction, which again, many of the same concepts that we've talked about before. I would say that other disorders we should like internet conspiracy theory addiction, or internet hate speech addiction, or cable news addiction, with subcategory Rachel Maddow addiction versus Sean Hannity addiction. I don't know about you, but I got friends that spend a lot of time on cable news. Not on cable news. Okay, so food addiction. As I said, food addiction is another one of the ones that really has a lot of data backing it up around hijacking the reward system. And when I'm looking at the list, gambling and food are the ones that kind of, because gambling is this behavior that's really kind of out there that has a lot of sort of impulsive reward and all that kind of stuff. And food addiction really has this potential for, high sugar, high fat kinds of food. Processed foods really are a drug in a lot of ways. They're not naturally occurring, they're not what our body's set up to react to, and so we can tend to overreact to them. It's important to recognize that we've got a huge overweight or obesity problem in our country that's leading to, as was noted on one of the slides, a lot of public health concern. Just to keep in mind that if you look at people who are obese, it's about 25% of them that meet food addiction criteria by taking one of these. The one that's always used is the Yale food addiction scale. And of this actually is a little unclear in the last one. So of people who are obese, only about 25% would qualify as food addicted. Of the folks that are food addicted, about 75% of them are binge eating. So when you read the articles on food addiction, a lot of them end up being about binge eating disorder. Although there is this broader category of it's not binging, it's just the person consistently, uncontrollably eating, as opposed to just eating a little more than they should or not exercising enough, and it adds up over the years. The Yale Food Addiction Scale is the usually well-accepted screening instrument for that, and there's a link to this at the end. Hypersexual disorder is one of the things about this disorder is it started out mostly being about hypersexual, in other words, how many orgasms, how many sexual encounters, and all that kind of stuff. The literature seems to be tending away from that for the most part to talking about these same criteria, regardless of how much or how often. Is it fitting with these distress, mood regulation, salience, loss of control, negative consequences, etc. And then again, it can manifest itself in a lot of different ways: masturbation, pornography, consenting adults, cybersex, telephone sex, etc. And again, this has been accepted onto the ICD-11, unlike the DSM-5, and they have their criteria, which again are very similar to what we just talked about. The Patho screening test is one of the other short screening tests that I found that I think is really nice. It could easily be included in some sort of a screening instrument if you wanted. Again, only 6 items to help screen for this. Shopping addiction, as we've said, more common among women, but interestingly enough, the rates on internet shopping, internet buying, are about the same for men and women. So it doesn't have that same distinction. There's a scale, again, that can be used to help ferret this out a bit. Exercise addiction, exercise in the sense of exercise that really is starting to meet criteria for being out of control, unable to manage, causing negative consequences, continually increase, unable to reduce how often or how much, using it as a mood regulator, those sorts of things. Workaholism, if you have time to attend these meetings, you don't really have a problem. So this is a tricky one, and this was one of the ones where the literature is most slippery, because a lot of this is culture bound, a lot of it has to do with other disorders like ADD and OCD and all kinds of other things, which was one of the interesting findings that dovetails with some of the things Dr. Krakow was saying. High relationship with ADHD and OCD and anxiety. And it's gotten more problematic in our particular culture. We tend to work more and longer than almost anyone else. I think we've had Japanese now, if I recall correctly. And the whole blurring of work and private time as people do at home work, et cetera, has gotten more and more difficult. Work addiction screening test is a well-regarded instrument in this regard. And so that kind of brings me to recommendations for clinical care. What does all of this mean in terms of screening, evaluating, referring, or providing counseling yourself? Well, what are the indications for screening for these disorders? Well, you could say, given the frequency, et cetera, it's not unreasonable to screen everybody, as part of their initial interview or their health interview. There's also the idea of screening for selected clinical encounters, focused encounters. If you're seeing someone with a mental health diagnosis, substance use disorder, overweight, fatigue, disordered sleep, these should be some of the questions that you're asking about. And if you do that, you can put that in context. You're here because of your fatigue. One of the things that can interfere with energy is sleep pattern and whatnot, and there's some things that can really interfere with that, like internet use, et cetera. Let me ask you a couple of questions about that. My experience with disorders of asking this question is to try and help you get help with the thing you're here for. The less people are going to resist, and the more they're going to be open in their response. And so how often are you going to turn up? How often does that mean? Well, for addiction medicine and psychiatry, I think means you should be asking these questions of everybody. There's a high enough overlap. Primary care, probably almost everybody. So what Dr. Arami and I did in our practice, Changes by Choice, is I looked through all these various instruments. I tried to find a good screening instrument. Couldn't really find anything other than the lie bet for gambling. But almost if you look at the brief screening instruments for substance use disorders like alcohol and whatnot, things like the CAGE questionnaire or single or double item questionnaires, they're almost always, have you felt a need to cut down on this? And have you felt like this is causing you problems? Those two questions often are just about as sensitive to the whole Michigan alcohol screening test or whatever else. And so I put together a screening instrument that basically started out with, do you smoke and do you want to quit? Because that immediately set it as, oh, Dr. Fincher's asking me about, or Dr. Arami's asking me something about, a habit that might be giving me trouble. And then went into the lie bet, and then went into basically, for the following behaviors, have you had felt like you need to cut down, or have you felt like it's causing problems? And I listed out these things with no to little to a lot. And then luckily I had a medical student with me. You want to put your hand up for the... So Paul was nice enough to put together a spreadsheet, collate all this information. We had an N of 72. Over about 3 weeks, we gave this to about 72 patients. We expect over the next 3 weeks we'll get another 72 or more, so we'll probably end up with about 150. But right now we've got 72 patients, and for those who scored greater than or equal to 3 out of 4, we said at least a fair amount of the time this is a problem, or this is a fair amount of a problem. We got about 39% who said one of these things has been a problem in the last 12 months, and about 42% said they had a problem with one of these things in the past. And if you remember that slide way back at the beginning, this is pretty consistent with sort of national averages. our practice is it's an addiction medicine outpatient, OBOT style practice. Most of these people are people who are on buprenorphine withdrawal, so that sort of thing. And interesting enough, I have not found anything in the literature which looks at that setting. But so we're pretty consistent. We got a fair number of people. And then what do you do if you do establish a screening or you do start asking these questions? Well, you gotta follow up. I have this abiding belief that clinicians only ask questions if they know what to do with the answers. Okay, so what I'm asking you right now, what Dr. Rami and I are doing right now is, we're not by any means considering ourselves experts, but we know this is something we should be doing. So we've got to put up with a little bit of discomfort asking these questions and starting to get this stuff out in the open and talking about it. And it's already starting to bring up some really interesting discussions with folks. At a minimum asking, so how much of a problem is this? Is this something you want to do something about or address, or you want to talk about more? We could consider giving them one of these diagnostic instruments to get a little more information. We could consider referring them to a network of therapists that we're in the process of developing who deal with these sort of issues. Or you can just deal with it as you would if it was a substance use disorder. If you're comfortable with that, you can frame it as being like an addiction, and then start asking the kind of questions you ask your clients or your patients if you're talking to them about their drug use. You know, how much, how often, tell me about whether you feel like this is out of control, something you can't control. What are you getting from it? What's the reward effect? You know, what's it like when you have to step away from the game, when you can't access the game or can't access gambling? Would you have any kind of a withdrawal? You know, the same sort of things you can ask if you're dealing with someone, talking with them about their alcohol or their cannabis or anything else. And this is a really nice article that Rusman et al. on sort of that very matter. Medications, I'll just talk briefly because there's not a lot. Naltrexone, interestingly enough, is the one that you might expect from everything Dr. Pekar said earlier that's showing the most promise. It's the only one that I found that actually had showed efficacy in a controlled trial, and that was for problematic gambling. It also has shown promise in uncontrolled studies for compulsive shopping and compulsive internet and skin picking, and some promising open label results for compulsive sexual disorder. Interestingly enough, there was this break point, and I was talking with Dr. Kranken about what the hell this is. So if the trials that showed benefit for some of these compulsive behaviors were at doses higher than we usually use. As you know, for alcohol or opiate dependence, you need 50 milligrams a day, maybe go to 100 milligrams a day. These studies were typically 100 to 150 to 200 milligrams a day. And paradoxically, there was a study quoted giving naltrexone 25 milligrams per day to 20 sexually active men, and they reported increased arousal and increased orgasm intensity. And so, among other things, I'm like, why am I not asking my naltrexone patients about that? You know, I've never read that as a particular issue. You know, a corollary is naloxone, which is Narcan. Interestingly enough, has been shown to exacerbate OCD symptoms. So there's clearly something going on with the opioid receptor system, right? And again, that hijacking we were talking about. Pretty much everything else is just a few, is uncontrolled or open studies or inconsistencies. So SSRIs have been looked at the wazoo, sometimes positive, generally not persistent. Bupropion showed some benefit in one small study. N-acetylcysteine, interesting enough, had a study that showed it reduced gambling urge in problematic gambling. If you remember, it was talked about in terms of cannabis by Dr. Pekar. Okay, so not a lot in the way of drug medication-assisted treatment or medications to assist treatment, but the naltrexone at a minimum has some interesting potential. So I'm going to finish just so you know that when you get the slides, which are going to come to your email on all the slide presentations, this is probably the part of the presentation I spent the most time on, was finding instruments so every one of these, you can go to that link and you can download an instrument that you can either print out directly or you can cut and paste and put together a screening instrument or validating instrument for all of these disorders. Now, all of that, the principal article that helped with that was Diagnostic Instruments for Behavioral Addiction. So if you want to look at some of the evidence behind that, that's the article to go to. So they contain, these spectrums contain elements of impulsivity and compulsivity. They're consistent with addictive disorders. There's only the one in DSM-5 and the two that were added to ICD-11, but nonetheless, prevalence of potential problems warrant attention. Psychosocial treatments do work where they've been studied and are similar to substance use disorders, and medications have shown mixed results, but some do consider clinical consideration. A lot of this, if you want more information, the ASAM Principle of Addiction has some great chapters on this. There's a book by Asher and Lavonis, Behavioral Addictions, that's, the nice thing about it is it has a link to videos online of clinicians interviewing people about these disorders. So they actually give you some practice encounter videos to watch. And then if you want more information about the DSM-5, Stephen Buser is an MD physician that went to Duke, is now in Asheville, and he wrote a great little book, DSM-5, Insanely Simplified. So just to finish with this comment about access to excess combined with a consumer culture, it's a great quote by Jay Phelan, and this relates to the internet in particular. All excessive stimulations of the reward circuitry that are not the behaviors for which it originally evolved are problematic, like crack and Krispy Kreme donuts. Internet porn, and I would add gambling, gaming, shopping, social media, is another manifestation of this mismatch. And this isn't a new thought. If we look to Wordsworth almost 200 years ago, the world is too much with us. Late and soon, getting and spending, we lay waste our powers. So this is nothing new, but it is something we can help resist as individuals and clinicians if we pay attention. Thank you. So if you're not coming back tomorrow, turn in your